اليوم ما رح أكون مشان أكون موديراتور. أنا حابة بس كنت جيت مشان أتشكر دكتور باتريك شروتر, دكتور جابرييل كاسو, دكتور جورج سافولدلي, les membres de la FLAVA, qui est une organisation latino-américaine reconnue à UK, de leur cordialité pour venir au Liban à leurs propres frais, ainsi que Dr Laurent Delaunay, qui devaient venir tous à leurs propres frais pour aider la société d'anesthésie dans leur congrès. C'est pourquoi je tiens à les remercier pour leur amabilité et leur affabilité et le fait qu'ils tiennent tellement au Liban. Mais malheureusement, la situation géopolitique dans notre pays et économique a fait qu'ils ne peuvent pas venir. Mais ils sont prêts à revenir quand la situation se rétablit pour nous faire le workshop de la FLAVA. Je tiens à les remercier. J'espère qu'ils m'entendent maintenant. Je tiens à les remercier. Je tiens à te remercier, Patrick, ainsi que Gabriel, et aussi à Georges et à Laurent Delaunay, qui ont voulu venir dans notre pays à leur propre fait. Je sais très bien, Patrick, combien tu as intérêt pour le Liban et pour l'évolution de notre science et d'aider. Vous avez le sens de l'humanité. Je vous remercie infiniment et aussi, je laisse la parole à Walid Nasreddin pour commencer à te présenter. Et bienvenue. J'aurais bien aimé vous voir dans notre pays que vous adorez. Merci bien.
Good morning. Professor Professor Patrick Schoettker is professor and head of the Department of Anesthesia at CHUV, University Hospital, Lausanne, Switzerland. He is the inventor of various airway devices, S-Guide, and AirTrack Mobile for AirTrack. He is a strong advocate of public-private partnerships and is a clinical initiator and lead of the medical virtual reality intubation simulation project that help clinicians to improve their understanding of tracheal intubation with the help of virtual reality for video laryngoscopy. He is a co-founder of BioSpectral, the startup that revolutionizes accessibility and actionability of connected remote hypertension patient monitoring, management, and research through software embedded in the global base of smartphone and connected devices. He is founding and acting president of the non-profit Fondation Latine des Voies Aériennes, FLAVA, which organizes annual difficult airway courses throughout Switzerland and financially support airway-related research. Professor Schoettker has authored more than 60 peer-reviewed articles, 25 book chapters, and is the editor of the book Perioperative Hemostasis, published by Springer. The word is yours, Dr. Schoettker.
Dear friends, dear colleagues, it is a fantastic and great pleasure for me to discuss with you the latest advancement in airway management. But to be quite honest, I am very sad that I have to do this from my hometown in Switzerland and not being able to discuss this with you lively in Lebanon. I strongly support you and I wish we will be able to see each other very soon. My name is Patrick Schoettker. I'm the head of the Department of Anesthesia at the University Hospital of Lausanne in Switzerland. And evidently, I'm keen on developing management in the airway. And I'm also very happy and proud to be able to host every year some friends from Lebanon who get some more practice and training in my own department. As you might know, the University Hospital of Lausanne in Switzerland is one of the 5 university hospitals, and we have a big team of anesthetists, 128 physicians, 220 nurses, 37 operating rooms, and we perform every year more than 30,000 anesthetic procedures. I'm also here as the president of the Fondation Latine des Voies Aériennes, which is a non-profit airway foundation that we created more than 15 years ago in Switzerland. And the only goal is to promote a better understanding of the airway management by promoting research, by also organizing workshops. And theoretically, we should have been here on Friday to organize an airway workshop with our Lebanese friends. But this is only promoted that we will do this next time. I was asked to talk about innovation, and I think I will give you some inputs about my favorite 5 innovations in the recent years, and maybe give you some insights about the future work that will be happening in airway management. 2022 and 2023 is definitely the year of video laryngoscopy. When I introduced this technique in my own department in 2007, I could discuss and decide how we were managing difficult intubation before. You can see that in blue. We're using the laryngoscopes, the bougies, the fibroscope, and all the available equipment. Since we introduced video laryngoscopy, the way we manage airway has become very, very different. And the same data can be found around the world in the different institutions since they introduced this. What we learned now over a few years that we've been doing these techniques of video laryngoscopy and indirect laryngoscopy, and this has been actually quite nicely described in this Cochrane review, more than 587 pages, is video laryngoscopy versus direct laryngoscopy actually promotes big advantages for our patients and big advantages for our doctors and physicians and nurses who help us to intubate. If you want to read this, I'm happy for you to do it, but I would rather propose you to read the conclusions that have been published in the British Journal of Anesthesia. And I think it's quite important to remember that whatever video laryngoscope you use, being it with a Macintosh blade, being with a hyperangulated blade, or with a channel blade, whatever you use, you have an increased rate of successful intubation in the first attempt, and you have a better glottic view, whatever you use. If you use the hyperangulated design of the blade, you're likely to have a better rate of putting the tube in the right place, therefore reducing the rate of esophageal intubations, and of course, result in improved rate of successful intubation in case you have an unexpected difficult airway. And whatever happens, whatever blade you use, there is a safer risk profile to use video laryngoscope. And this is a strong message. And I think, although this is what we have been discovering over the last 50 years, the literature goes straight in that direction. Many trials, I won't go over all the trials, but it's interesting to see when you perform a big trial in a big journal and you try to promote the differences between video versus direct laryngoscopes, the trials have to be stopped because the power, the advantage of the video laryngoscopes is so strong that you don't need to include any more patients to demonstrate the advantages of the video laryngoscopes. Some other studies related to different devices, as here the McGrath, go in the same directions. Interestingly, if you look at this picture, you could believe that this is the place you want to put the tube in, such as the vocal cords. But if you have a better visualization, you notice that it's an impersonalization of the glottic opening, and it's actually the esophageal. By promoting the use of video laryngoscopes, you prevent the unrecognized esophageal intubation. And why are you able to do this using the laryngoscopes? Well, if you use CO2, you know where the tube is, at least in the trachea. If you have a routine use of the laryngoscopes, you bring the team around the view and you get the input from all the team to confirm correct placement. So if you want to prevent esophageal intubation, use the laryngoscope. So this is a recommendation whenever feasible. It improves the view as it allows the team to talk and discuss and interact and confirm or help you decide about the proper tube position. And this is a strong message why we should use the laryngoscopes in the future. And you have here a visualization of how I teach the laryngoscopic intubation in my department. I teach, and sometimes, even as a teacher, I can't reach the goal, and I get the input from the junior. You will see his finger saying, hey, dude, put the tube over to the left, and this will help the team get a better visualization and a better management. And this is what I like about using video laryngoscopics tools to intubate. It promotes a horizontal teaching and learning experience. I'd like to conclude the slide about the discussion about the laryngoscopes. I have introduced VL in my department in 2007, and since then everyone uses it all the time. Actually, this is not true. This is true when I am around. The literature says you should use it all the time. Even if we have been doing that for more than 15 years in my department, we still don't use it all the time because there is some reluctance. And that's why we are pushing now to promote use video laryngoscopes all the time. Know a device, take a device, use a device, and then get practice, use it. And this will not kill or destroy the direct laryngoscopic usage. It will just put it in a different kind of patients depending on their needs. I think as airway providers and health departments, we must understand that teaching is a very important thing. Every time you introduce a new device, you use evidently the skills. And for that, we need to implement teaching strategies. And I think this is the second point I want to highlight about the future. A fool with a tool is still a fool, so we need to teach. And the power of informatics, the power of progress is strong that we can now teach in a better way. We've been trained by the past on the patients. Then we went over to mannequins. And now the future, or actually the right now, is the way to train virtual availability. You can see here a project we've been doing, and you might have come across this project because we've been showing that when the use of electronics, for example, at different countries, international French countries. See it here, you immerse yourself wearing this in my own department, but if we construct it and you can train the handling of specific devices, especially integrated things that have been identified with practice problems, take the right equipment, the right size for the device. This is a very strong and very powerful tool. See here, this same time and device. We use the last.
How do I find it? Really good, very realistic. I felt like I was totally lost within the virtual reality world.
Realistic. What we changed. This is the power of informatics, the power, as we call it, of ChatGPT, for example. We have created an avatar of a teacher, a very motivated teacher. And actually, you can see now teacher is.
Welcome to the McGrath-Mac video laryngoscopy simulation.
Who created and developed you?
The teacher is connected to the internet.
I was created and developed by a team of virtual reality developers in collaboration with Dr. Patrick Schoettker, a renowned anesthesiologist and medical researcher.
You know what?
The purpose of my development is to assist.
It's ultra portable because you can use this on the available virtual reality headsets. You can validate the anatomy, you can validate the handling and design, and based on the simulations, histories and scenarios, you can train specific situations. And this is, of course, the future of teaching when we use virtual reality or augmented reality. The third point I want to highlight, we have ultrasound equipment in quite some instances we use for nerve blocks, we use them for intravenous lines. How about using them in assessing the airway management? You see here Michael Sells-Christensen will describe the first, an easy way to identify the membrane, the cricothyroid membrane, and we teach it every year at the European Society of Anesthesia conferences. And it's fascinating, by using very simple landmarks, you're able actually to identify the cricothyroid membrane, and for this, you improve the rate of success if you would need to be in a desperate situation, if you would need to introduce a scalpel, a bougie, or a front of the neck access. I think this is a strong message. One of the new things is understanding the role of ultrasound, and these equipments of ultrasound are normally quite easily obtainable around the operating rooms as their standard practice for many instances. And not seldomly, we identify the landmarks. And what's interesting also for the teaching effect, you have here two landmarks. The first one was identified by palpation. And I will always ask my residents, where would you introduce or cut the neck? And they would make a mark. And then we will double check it with your ultrasound. And it's interesting to see how the airway is a dynamic process, and depending how you position the head, the landmarks will be different. The fourth news, I would say, is that evidently, as we all know, air goes in and air goes out. If there is a massive stenosis, if there is a big mass that provides air entry but not always outside, there is a big reflection. And there have been made many big improvements in the way we introduce and get air out. And I think the power of venturi is something very nice that we could reflect. You can see here a very basic equipment that allows to use the inlet as the outlet only by understanding and by using the venturi effect. By introducing a stylet, for example, it's a hollow lumen which allows air to go in. If you apply a venturi effect to the inlet, you'll be able to use the inlet as the outlet. So I love this technique, which can be life-saving in some specific instances. And the interesting progress is, out of this technique, very basic venturi effect technique, they have actually made a ventilator, which has revolutionized the way we use the ventilation. It's not only power, it's not only pressure controlled or ventilatory controlled or volume controlled, it has now become flow control. If you think about how the patients breathe or how we breathe in the flow effect and not in the pressure or volume. And I think the results are coming out more and more. Very interesting papers during the COVID situation. Also, the flow control ventilation can bring some advantages, and it allows you to insert and inflate lungs through small lumen tubes, which can be very interesting in some instances. Note that kind of device because it's a different way to think about ventilation and respiration. And finally, oxygen. I would like to challenge you. Our goal is to bring oxygen to the lungs and, of course, oxygen to the brain. We have always been doing this by using tubes into the trachea, tubes that allow the ventilators to push air in and to get the air out. If you look at how the future of anesthesia is especially related to airway, we always want to bring oxygen in and out. What we will only do it is maybe we can do it without tube. And you know, this is the picture of Professor INT'L Patel from London, who's been the first one actually to promote the transnasal humidified rapid insufflation ventilatory exchange technique, the THRIVE technique. By putting a nasal prong on the patients and using high, warm, humidified oxygen, you'll be able to promote 70, 80, 90 liters a minute. And by this, according to his paper, which was published a few years ago, you can always and almost ventilate the patient. The literature has been a bit more complex now, and the question of the ventilatory exchange has been questioned, and there's probably not that much of ventilation, but one thing for sure, there is a strong effect on the ventilatory effect and a strong effect on the oxygenation, which allows you to buy time for safety for your patients in case you have a difficult intubation or difficult airway. What we tend to do in our institution, depending on the situation, the type of surgeries, more and more we do ventilation or oxygenation without the tube, tubeless anesthesia. By promoting the ventilatory exchange of 80 liters of highly oxygenated, highly humidified warm oxygen, we are able to maintain the oxygenation value at quite high levels, or at least clinically sufficient levels, that allows us to bring oxygen to the patient in such a way that everything is safe for the patient without any tubes. And depending on indication, depending on the type of patient and the type of surgeries, this is an interesting solution. So I would say in the fifth revolution, the fifth new way of thinking about airway management is actually to use intubation, to use airway management without intubation. And this is just one example using high flow oxygen. You could use more and more. There's some very interesting papers about using a cuirasse, and out of the thorax machine that actually compresses and expresses air that allows you to again oxygenate and ventilate the patient tubeless without any tube. An interesting study or an interesting review about the 5 years on and into the COVID-19 area using the high flow. We have gone from very say, COVID is a bad thing about using high flow to why shouldn't we use high flow for COVID patients as well as we increase the administration of oxygen. A Swiss study that has come last year is actually questioning, as I was telling you, the way of, is it really a ventilatory effect? Well, maybe not as much, but what is important for us is probably the CO2, but much more important than CO2 is the oxygen level. Finally, I would like to conclude the airway management of the future. My five topics. Optics. Optics will change and actually have changed the way we look at our airway. By putting optics on blades, depending on which size, depending on which format, being Macintosh blades or hyperangulate, we see things and we understand the anatomy. And by understanding the anatomy, we're able to assess the strategy and decide what's the best way to manage the airway, putting a tube into a trachea. When we teach, we need to teach the way we can teach now. Virtual reality or augmented reality has a promising future. There are a few projects around the world that actually use it, and with the power of informatics, you can use ultra-portable devices to teach. And by that, you can teach and learn in the front of your operating room, at home if you wish, wherever you are. Ultrasound. Ultrasound is a fantastic equipment which are widely available. Why shouldn't we use it to assess airway? You can use it to identify the landmarks in the front of the neck. You can use them to identify the trachea. You can use them to identify the thickness of the tongue. There's a strong future of using ultrasound. Ventilation. We were trained by pressure control or ventilatory setting up the settings of volumes. How about thinking in a more physiological way, such as flow control? Strong support flow control allows you to ventilate your patients through small lumen tubes. And finally, oxygen. Oxygen is our best friend. Oxygen is the best friend of our patients. Why shouldn't we use it? High flow, warm, humidified, and by that you open the door of doing tubeless anesthesia. And this is also the future of our patient. With this, I'm very much thanking for you to be listening to my talk.